Hello everyone and welcome to MedEd. I'm Dr. Patil and we are continuing our Reed Harrison series. And in this series, we will be talking about muscle disorders. I will try to do two sessions on muscle disorders because 30 or 40 minutes may not be adequate to cover everything that we need to know from the perspective of disorders of muscle. Okay. Now let me begin by summarizing what we know so far about muscle disorders. We have studied how to identify the site of lesion in a patient presenting with weakness. And we understand that if a patient has, let me say, a lower motor neuron damage, he presents with distal weakness. Along with that, tone, deep tendon reflexes, and Babinski will all be down, right? On the other hand, if someone presents with weakness because of damage to upper motor neuron, in the sense spinal cord, brainstem, subcortex, or cortex, obviously he will present with weakness, and the distribution of weakness depends on the site of damage. And on examination, we will notice that the tone is increased, deep tendon reflexes are exaggerated, and whenever there is a damage to the pyramidal tract or upper motor neuron, we also have a positive Babinski sign, right? Okay, so what we will do today, we already know about muscle. And what did I tell you about the muscle disease? Most commonly, when muscles get affected, generally larger group of muscles are affected more than the smaller group of muscles. And that's why I made a general statement saying that muscle disorders present with proximal muscle weakness, weakness of muscles around your shoulder girdle, pectorals, and weakness of muscles around your pelvic girdle or hip joint, right? So that's the usual presentation of muscle disorders. But I'm again repeating usual presentation. Why am I emphasizing on this? Because today we will do a little deep dive into muscle disorders and understand various other presentations of muscle disorder. But basically speaking, majority of patients with muscle disorder that come to our OPD are because of common causes, and common causes generally affect proximal muscles. And whenever proximal muscles are involved, what are going to be the presenting complaints? People will have difficulty to raise their arms. They will have difficulty to comb, difficulty to brush, difficulty to lift objects from the floor. They will have difficulty to get up from the sitting position. They will have difficulty to climb stairs. These are usual presenting complaints of patients with muscle disorder, right? So with this summary, let me start today's topic, that is about the muscle disorders. Okay. Now, what are we doing today? First thing we will understand is how to make a list of disorders affecting the muscles. And there are various ways, right? One way we already know, like broadly speaking, based on the causes, we have already learned how to classify the muscle disorders, like inherited myopathies, endocrine myopathies, inflammatory myopathies. That is one way of classification. But today, the classification that we will be learning is based on the pattern of muscle involvement or pattern of weakness. So the first class here will be proximal muscle weakness. Those muscle disorders which present with proximal muscle weakness, which is the most common. And that is why generally we say whenever you think of muscle disorder, think of proximal muscle weakness. This pattern of weakness is also called as limb girdle weakness. Means limbs and shoulder and pelvic or hip girdles are the ones where muscles around that region are becoming weak. So it is also called as limb girdle weakness or proximal muscle weakness. What all disorders present with this? Among these, obviously, we know that endocrine myopathies are the most common causes for proximal myopathy, right? Diabetes, acromegaly, many of endocrine disorders, Cushing syndrome. Then most of the muscular dystrophies like Duchenne muscular dystrophy, Becker's muscular dystrophy, limb girdle muscular dystrophy, they are all, most of the dystrophies present with proximal muscle weakness. Then we have disorders which affect the mitochondria. Very, very important because muscles need lot of ATPs to be able to do their work. And where is the synthesis of ATP happening? We obviously need mitochondria for the synthesis of ATP. So if mitochondria dysfunction, ATP generation is impaired and muscle function will be impaired and patient will present with proximal muscle weakness, right? Can anybody give me an example of a mitochondrial disorder? Nilanjana, Nusaiba, and Sutapa, good evening, everyone. Good evening, everyone. An example for a mitochondrial disorder. Basically, these are the disorders where either mitochondrial metabolism is disturbed or the mitochondrial genes are affected. Myasthenia gravis is not a mitochondrial disorder. So there are two examples I want you to remember. The first one is Kern-Serre syndrome. Kern-Serre syndrome. Earlier in the first week of August, we will be covering mitochondrial disorders in detail. So I'll discuss more about these. The second one is called as MELAS. Duchenne muscular dystrophy is not a mitochondrial disorder. It is a muscular dystrophy, right? So it is a dystrophy. MELAS. MELAS. So these are the two disorders which affect mitochondria and there is involvement of the muscles. Clear? Then there are certain inflammatory myopathies where muscle gets inflamed. Here, most importantly, I want you to remember autoimmune myopathies. Autoimmune myopathies. And under that, there are two important ones. One is dermatomyositis. As the name says, skin and muscle are inflamed. Dermatomyositis. The other one is called as polymyositis. Means multiple muscles are inflamed without the involvement of skin. Right. So these are all conditions where patients present with proximal muscle weakness. Not very difficult to recognize or diagnose. Because see, if a diabetic presents with difficulty to comb, difficulty to lift objects, difficulty to get up from sitting position, then I know it is diabetes which has led to the myopathy, right? So I will call it as diabetic myopathy. If a patient with Cushing syndrome presents with similar symptoms, obviously I will make a diagnosis of an endocrine myopathy, cause being Cushing syndrome. All other features of Cushing syndrome will be present in the patient, like moon faces, buffalo hump, gynecomastia, pendulous abdomen, right? The purplish striae, all of them will be evident. Okay. So what we will do from this proximal muscle weakness as a presenting feature, we will study a little bit about the dystrophies today. Okay. Then it is one of the mitochondrial disorder where there are abnormalities of the mitochondrial genome. I think all of you know that apart from the genetic material that we have in the chromosomes, inside the mitochondria also we have circular DNA, right? So certain abnormalities of that DNA impair the mitochondrial function and they can present with muscle weakness, brain dysfunction and various other complications including cardiac dysfunction. Okay. Then autoimmune myopathies are also not very difficult to recognize because when the patient presents with muscle dysfunction, right, often they have pain because there is inflammation. That is one point. Second thing, when you do the antibodies, you will be able to find the appropriate antibodies for the diagnosis. And if it is dermatomyositis, these patients, along with the proximal muscle weakness, they have characteristic rashes. Let me show you some of them. Typically, patients with the dermatomyositis, apart from having proximal myopathy, they have certain skin features, and two are important skin features. The first one is called as Gottron's papules. So on the dorsum of the hand, right, over the joint, there will be papular rashes that you see here. So we call them as Gottron's papules. And generally, there is violaceous rash around the eye socket. So we call it as heliotrope rash. So these two rashes, along with proximal muscle weakness, diagnosis is very clear. That is dermatomyositis. That is a repeatedly asked MCQ, sometimes image-based question. Another rash you should be familiar is these patients also have erythematous rash around the neck. Right? That's a place where we wear the shawl. So it is also called as shawl sign. So Gottron's papules, heliotrope rash, and shawl sign. These are pointers for us to suspect that the patient may be having dermatomyositis. So these are all disorders which will present with proximal muscle weakness. That's a common thing, right? But there are some muscle disorders which present differently. So there is also a set of disorders where distal muscles are predominantly affected, but they're extremely rare. That is why we make a generalized statement saying that when you think of muscle, think of proximal muscle weakness, because everything else that we're going to talk today are extremely rare. So all I want you to remember is one example for a distal muscle weakness. That is the MCQ that they usually ask. Which of the following muscle disorder presents with distal weakness? That's an MCQ, and you only need to remember that. Beyond that, it is mostly the dystrophies and mitochondrial disorders and inflammatory myopathies. Those are the MCQ topics. So that distal muscle weakness that you need to remember is Weylander's myopathy. Weylander's myopathy or Weylander's dystrophy. That's a distal muscle disorder. It's a muscle disorder but presents with distal weakness. Okay. Then you have a set of muscle disorders where they do not present with classical proximal muscle weakness, but rather what we call as scapuloperoneal weakness. Scapuloperoneal weakness. Now, what does that mean? So there is involvement of muscles in the scapular region, and there is usually sparing of deltoids. The subscapularis, trapezius, and other muscles are involved of the scapular region, but there is sparing of the deltoid. There is involvement of the biceps, that is humeral region, but sparing of the forearms. Okay. So we call it as scapuloperoneal weakness. Apart from that, lower limb weakness. Okay. There are two examples where you get this scapuloperoneal weakness kind of presentation. One of them is called as facioscapulohumeral dystrophy. Fascio, face. So far what we know, when we think of the proximal weakness and involvement of face, we should think of the neuromuscular junction disorders like myasthenia gravis. But rarely, we have muscle dystrophies where patients can present with face, scapular region, humeral region, right, and rarely lower limb, facioscapulohumeral dystrophy. And there is one more disorder called as Emery-Dreifuss muscular dystrophy. Emery-Dreifuss muscular dystrophy. So I will take you through some pictures. You will be able to understand better. Emery-Dreifuss muscular dystrophy. So these are two disorders where you have this scapuloperoneal kind of weakness, not the classical proximal muscle weakness. Okay. Apart from these, we have certain muscle disorders where weakness is not persistent. See, again, when we initially discussed about muscle disorders, right, in the previous sessions, I told you that variation in weakness is hallmark of neuromuscular junction disorder, particularly diurnal variation. Within a day, sometimes it is better, sometimes it is worse. But you will also come across some patients who have muscle weakness appearing in episodes. Not always they are weak, but note diurnal variation. Variation is hallmark of myasthenia gravis and the Lambert-Eaton. So these disorders, we will call them as episodic weakness. And whenever they are weak, often they have myoglobin in urine. So episodic weakness or episodic myoglobinuria. Okay. Can anybody give me an example where muscles get affected in episodes? They get affected in episodes where patients present with episodic weakness. How many of you have heard of this hyperkalemic periodic paralysis, hypokalemic periodic paralysis? So you have to remember a set of disorders called as channelopathies. Now, what do I mean by channelopathies? There are sodium channels, potassium channels, calcium channels. A contraction of muscle is a very complex process, and obviously various electrolytes are necessary for us to be able to contract the muscle. If the channels which transport the electrolytes from extracellular environment to intra or intra to extra, if they are disturbed, that can affect the muscle function. But obviously, when the electron level goes a critical level below or above, then the symptoms will appear. Otherwise, in between, when the electrolytes are fine, patient may not be having symptoms. So that is why these patients do not have a persistent weakness like you have in mitochondrial disorders or the muscular dystrophies. They occur in episodes. So whenever you think of a patient presenting with episodic weakness or myoglobinuria, you have to think of channelopathies. Channels, sodium channels, potassium channels, or calcium channels being affected, right? So this is the approach. Now there is also another set of patients who have muscle weakness, but along with muscle weakness, there's a characteristic finding, which is they have difficulty to relax the muscle. Means they may be able to reasonably contract the muscle. Strength may not be significantly diminished in contraction, but once you have to release, it's very difficult. It's very difficult. Can anybody give me an example? You just search in the Google, in the YouTube, you will get plenty of videos where they ask the patient to hold a keychain or a pen in their hands, and then they ask them to release, and they're not able to release it. What is that phenomenon called where you can contract the muscle, but you cannot easily relax? What is that phenomenon called as? The phenomenon is called as myotonia. The phenomenon is called as myotonia. Notes you will get it on the PW Meta Telegram channel. All the videos that we do on this YouTube channel, the notes will be available. It is called as myotonia. What is myotonia? Impaired relaxation of muscles. We call it as myotonia. There are such disorders. Examples I will quote. There is something called as myotonic dystrophy. Myotonic dystrophy. There are two types of it: myotonic dystrophy type 1 and type 2. And then there is another disorder called as myotonia congenita. Myotonia congenita. These are the conditions where patients present with weakness. In some of them, it may be proximal. In some of them, it may be distal. But along with that weakness, they have difficulty to relax. So when they hold on to some objects, they cannot let go of the objects, right? They're standing in the bus holding the rail, and then when they have to get down, they need to struggle to get themselves released from the railing, right? So this is what we call as myotonic dystrophy and myotonia congenita. This is a basic we should know. Based on the pattern of weakness, we will be able to make a clinical diagnosis. If it is proximal muscle weakness, first thing that should come to your mind is endocrine disorders. Okay. Then other than that, if it is, especially there is family history, you can think of dystrophies, then mitochondrial disorders and inflammatory myopathies or autoimmune disorders. Distal muscle weakness, for now you have to remember only one, that is Weylander's myopathy. If the patient says that I become weak intermittently, muscles become weak intermittently, on examination you're getting all other muscle weakness findings, but not the weakness that is persistent, you should think of channelopathies most importantly. If the distribution is scapuloperoneal type, think of facioscapulohumeral dystrophy or Emery-Dreifuss dystrophy. And if patient has difficulty to relax after contracting a muscle, think of myotonic dystrophy or myotonia congenita. Clear? Okay. So what we will do today is we will understand some of the dystrophies and then we will continue further. So Weylander's myopathy is also one of the dystrophies where it does not affect proximal muscles, it affects the distal muscles. It affects the distal muscles. Okay. So when we say proximal muscles, most of our dystrophies, most means whatever names that come to your mind, like Duchenne muscular, Becker's, limb girdle muscular dystrophy, majority of them affect the proximal muscles. Means they affect what? They affect the muscles around your shoulder joint, pectorals, and muscles around your hip joint and the thigh muscle. That is the usual involvement, right? That is what we call as proximal. So today we will study about two important muscular dystrophies. One is Duchenne muscular dystrophy and the second one is Becker's muscular dystrophy. Good thing is both of them have a similar underlying pathology, but the presentation and the way the disease progresses are different. So first what we will do is we will understand the cause. The mutation for DMD and BMD is both in same. It is in a muscle protein called as dystrophin. Mutation in a muscle protein called as dystrophin. This mutation leads to Duchenne muscular dystrophy and Becker's muscular dystrophy. Both of them are inherited as X-linked conditions, X-linked recessive conditions. Then if the mutation is same, both of them are inherited in the same pattern, then why we have two separate conditions? It is because what mutation does to the outcome. So if I have a mutated dystrophin, if it is DMD type, right, then what happens? There is absolutely no production of this dystrophin protein. The dystrophin protein will be totally absent. But if I have another type of mutation in the dystrophin where the production is not absent but reduced, I will have two kinds of disease now. When the dystrophin protein is totally absent, it will severely affect the muscle. The patient will present much early with more profound weakness. On the other hand, if it is reduced, the patient will not present early, usually not in the childhood. They present late in the teenage or in the early adulthood. And it may not impact the patient's physical strength as much it would do if it is totally absent, right? So there are two most important muscular dystrophies that we should know, Duchenne muscular and Becker's. Both of them are due to mutation in dystrophin. Both of them are inherited as X-linked recessive traits. But in DMD, the mutation makes the gene to go absolutely silent. So there is no dystrophin protein present at all. And in BMD, the mutation leads to a quantitative defect, in the sense dystrophin will be produced, normal one, but the quantity of production will be reduced. Yes, because it is X-linked, it predominantly or typically affects the males. So whenever you open the books and see patients with muscular dystrophies like DMD or BMD, you don't see a girl child's image, you always see a male child's image. Okay. Now, what clinical features they present? The DMD and BMD, both, as I've already told you, they affect the proximal muscles, group of muscles, right? Mainly, they affect the lower limb more than the upper limb. Upper limb involvement will obviously be there, but first it starts in the lower limb. Why? Because most of the proximal myopathies, they affect based on the size, and we know that the leg muscles are probably the largest muscles in whole human body. So that's why they get affected early. Now, it is an inherited disorder. So obviously, at what age I will get to know that, okay, this particular child has the Duchenne muscular dystrophy or Becker's muscular dystrophy. The usual age of presentation of Duchenne muscular dystrophy is 3 to 8 years. By this time, some signs of muscular dystrophy will start becoming evident. But if it is Becker's dystrophy, it may take second to third decade. Means you may not get to know that a patient with Becker's muscular dystrophy has the disease in their first 10, 12 years of age. After that, some signs might start becoming evident. Many patients may not even show the signs of muscle dysfunction. They will only show the signs of cardiac dysfunction later in the adulthood. That is why if you ask me which one is more severe, obviously DMD, because in DMD there is absent dystrophin and that's why it presents much early. In Becker's, there is reduced quantity of dystrophin, so patient will not present early, they will present little late. Okay, so let us first concentrate on the Duchenne muscular dystrophy because that is the topic that we generally ask during bedside discussions or in the MCQs. Okay. Now, if I have inherited this mutation making the dystrophin to go completely absent and I have Duchenne muscular dystrophy, right? How the symptoms will progress. So somewhere between 3rd to 8 years of age, I will start showing my early signs of muscular dystrophy, right? What are going to be my early signs of dystrophy? Before 3 years of age, I may not have major evidence of muscle dystrophy or weakness, but after 3 years, slowly the evidence starts becoming clear. And as I've already told you, the lower limb muscles are the first affected. So because the lower limb muscles are first affected, I will start showing the signs of lower limb weakness. I might have difficulty to get up. Okay. And please remember one important point. One important point. That is in patients with dystrophy. Why are we using the term dystrophy? Dystrophy. We're using the term dystrophy because here the muscle fibers that we generally see, right? Muscle fibers are getting replaced by fibrous and fatty tissue, fibro fatty tissue. We're losing the muscle fibers, but muscle is not shrinking in size. Muscles are being replaced, muscle fibers are being replaced by fibrous connective tissue and fat. So because of that, the muscle size increases. Muscle size increases. Strength, because muscle fibers are gone, strength decreases. Right? So at this time, like somewhere between 3 to 8 years of age, patient will start developing the weakness of leg muscles, right? Means muscles around his pelvic girdle. And because of this, we will start noticing that he develops the lumbar lordosis. He will develop, right, absolutely right. He will develop lumbar lordosis and the calf muscles, as you see in this image, right? They start developing what you call as pseudo hypertrophy, means not truly enlarged because not increased muscle fiber synthesis is happening. Muscle fibers are being replaced by fibrofatty tissue. So we call it as pseudo hypertrophy. Pseudo hypertrophy. Okay. Now, as the time progresses, right, as the time progresses, the more and more muscles start becoming weak. And by the time they reach their second decade, means somewhere between 12 to 15 years of age, they become completely crippled or bedridden and they start developing the deformities. That's the usual progression. Means between 3 to 8 years of age, they start developing the lower limb weakness. They have difficulty to get up from the sitting position. As the time progresses, they'll start developing upper limb proximal weakness. Okay. During this period, you will start noticing that they have lumbar lordosis. And if you ask them to walk, right, they generally have this tiptoe walking. Means they walk on the tips of the toes. So we call it as tiptoe walking. Tiptoe walking. And during the same period, we can also unmask the proximal muscle weakness of the lower limbs by asking or by looking at how they get up from the floor, right? And I think all of you are familiar with this sign called as, what is the sign called as? Where when you ask this patient to get up from the sitting position on the floor, because they have the weakness of the pelvic girdle muscles and the anterior thigh muscles, they cannot push themselves up without taking the support of upper limbs. They slowly get into a prone arched position. They make a triangle of their body. Then they lift and try to push their upper body up or erect by using their upper limb on their thighs. and then somehow they achieve this erect posture. This sign is what we call as Gover's sign. Gover's sign. So by what age this sign usually becomes evident? Somewhere between 3 to 8, 9 years of age, the Gover sign becomes evident. But as the time progresses, they become increasingly crippled. They become very, like, they experience difficulty to do routine activities. Eventually, by the time they reach their second decade, between 12 to 15, 16 years of age, they become confined to wheelchair and they may become confined to the bed. That is the usual progression. Okay. Now, please also remember that these patients, this is the usual progression, these patients are also at increased risk of dilated cardiomyopathy. Dilated cardiomyopathy. Yes, yes, yes. So this Gover sign is not highly specific for the Duchenne muscular dystrophy. We have to remember that Gover sign primarily indicates that there is weakness of pelvic girdle and anterior thigh muscles. That's it. And this can happen in various disorders, classically described in a patient with Duchenne muscular dystrophy. Okay. Now, why do these patients die? Most often, Duchenne muscular dystrophy patients die because of complications of dilated cardiomyopathy. Means their left ventricle, see, muscles, even our heart is a muscle. So that also gets affected. So the left ventricle starts becoming progressively weak and dilates. And that results in two outcomes. One, these patients can develop heart failure with very low ejection fraction, reduced ejection fraction. And second, they become prone for ventricular tachycardia and ventricular fibrillation. And one such VT or VF attack, we may not be able to revive them and we end up losing the individual. Okay. Now, if I get a individual, especially in the first decade, with this typical difficulty to get up, tiptoe walking, lumbar lordosis, and I can demonstrate that he has Gover sign, clinically, I'm making a suspicion that this is most likely Duchenne muscular dystrophy. Now, how do I make a diagnosis from this clinical suspicion? So please remember, guys, for the diagnosis, in the past, we used to do muscle biopsy. Biopsy used to be the investigation of choice, because in the biopsy we could prove that muscle fibers are being replaced by fibrofatty tissue. That's how you can say that this is a dystrophic condition. But nowadays we don't need it. We don't need the muscle biopsy because we can directly do the genetic study to identify this dystrophin mutation, right? So that is why it is the investigation of choice right now is the genetic studies. There are various types of genetic studies to identify dystrophin mutations. Dystrophin mutation. If there is absolutely no expression of dystrophin, then we know that it is Duchenne muscular dystrophy. If there is reduced expression of dystrophin, then we know that it is Becker's muscular dystrophy. So what sample we should take for this? It is not the muscle, right? We take the circulating blood leukocytes, extract the DNA from that, and then see if the dystrophin is normal or not. That's how we make a diagnosis of Duchenne or the Becker's muscular dystrophy. For both of them, it is the same investigation. Okay. So now getting back to the initial discussion. What we learned, Duchenne muscular dystrophy is an X-linked inherited muscle disorder characterized by presenting as proximal muscle weakness, usually presenting in the age range of 3 to 8 years. That is where the initial signs become evident. What are the initial signs? Difficulty to get up from the sitting position, right? Lumbar lordosis becomes visible, and tiptoe walking on their toes instead of properly grounded feet. The Becker's muscular dystrophy patients, they generally become evident in second, means in 15, 16 years to up to even 30 years. So second to third decade is where these patients present. And as I have already told you, some of them may not even develop the muscle weakness. Only heart itself may be affected. And the rest of the muscle may be mildly affected. You may not even notice that you have weaker proximal muscles. Some of them, yes, they present with proximal muscle weakness in second to third decade. These are the patients which require a little more investigation because differential diagnosis start increasing. If someone presents in their 25, 26 years of age with muscle weakness, endocrine myopathies and everything else becomes an important differential diagnosis. If someone presents with proximal muscle weakness in 3 to 8 years age range, first thing that should come to our mind is Duchenne muscular dystrophy. So one last question I have. Among the DMD and BMD, which one do you think has a better prognosis? That is something that is routinely mentioned in our MCQs in terms of prognosis, which carries better prognosis. Obviously, dystrophin has an absent, DMD has absent dystrophin, presents much early, progresses much faster. So obviously that will have the poor prognosis. While the Becker's muscular dystrophy, dystrophin, though quantity is less, quality wise it's fine. It is still being produced. So that's why you present late and you may be able to live to 50, 55 years of age. So BMD carries a better prognosis and DMD carries poor prognosis. Simple. Okay. Now that is about the inherited proximal muscular dystrophies. Similarly, we just learned that there is one more pattern of muscle weakness presentation, that is the scapuloperoneal weakness, right? We had learned about two examples, facioscapulohumeral dystrophy and Emery-Dreifuss muscular dystrophy. Sayak Chakrabarti, yes. So the cardiac dysfunction as well as the severity of muscle involvement is more with the Duchenne muscular dystrophy in comparison to Becker. So that is why the overall prognosis with Becker's is better. Okay, I didn't talk to you about the management, right? Unfortunately, as of now, we don't have anything effective to manage these patients. So when it comes to management, it is more about supportive physiotherapy, nutrition, and all. But studies have shown that low dose steroids, glucocorticoids, they can slow the progression of DMD. The benefit is not seen in patients with BMD, progression of Duchenne muscular dystrophy. So sometimes when you have a patient with DMD and they're rapidly progressing, we do add a small dose of steroids that slows it down. Basically, it reduces the fibrofatty conversion of the myofibrils, slows down the rate, and that's why it may be helpful. Otherwise, it is mostly the supportive care. So if you ask me what is the mainstay of treatment, it is the supportive care. Supportive care. What is the most common cause of that? It is the cardiovascular complications, heart failure, and arrhythmias. Sayak, absolutely right. Okay, so now let us talk about that, the scapuloperoneal pattern of weakness, taking an example of facioscapulohumeral muscular dystrophy. Inside medicine, especially name of the disease holds a lot of information. Now, when you look at this name, right, it clearly tells that there is involvement of face, there is involvement of scapular region, there is involvement of humeral region, right? So that's why it's called as facioscapulohumeral muscular dystrophy. So the Samantha, supportive care basically means as the time progresses, right, they start becoming crippled. Crippled in the sense they will not be able to do basic physical activities. So we now need to rehabilitate them to do that. See, for example, as my lower limbs progressively keep becoming weak and I have difficulty to get up from sitting position, then it is better for me to be on a wheelchair so that I don't need to get up. I can mobilize myself with the help of wheelchair. So those are like rehabilitative steps that we take because of the disabilities that we cannot cure. That's the supportive care. Okay, so otherwise there is nothing specific we can do for these patients as of now. Most of the patients with Duchenne muscular dystrophy do not live to the adult life. They generally die in their second decade or early third decade. Barely ever, as an adult physician, you will be able to see a Duchenne muscular dystrophy patient coming to your clinic. It is mostly pediatricians who handle, and then unfortunately, they do not live enough to become an adult person to see an adult physician. Okay. Now, these facioscapulohumeral muscular dystrophies. What is the cause? For the DMD, BMD, it is a mutation in dystrophin that was responsible. Right? For the facioscapulohumeral muscular dystrophies, there is increased expression of a gene called as DUX4. Increased expression of this gene. So because of this increased expression, see, normally this DUX4 gene, after the muscles are completely developed, is suppressed. So you might know from your biochemistry that whatever genetic material we have, some genes are expressed, some genes are suppressed. Suppressed genes might have had some work in the past or maybe in the future, but right now they're not supposed to be active. But unfortunately, patients with this, because of certain mutations, this DUX4 gene becomes active again when it is supposed to stay suppressed throughout our life after the initial activity. So its reactivation or increased expression results in the muscle dysfunction. Now, what muscles get affected here? The first muscle to get affected, right? The first set of muscles to get affected in these patients are basically the facial muscles. Facial muscles. What facial muscles are predominantly affected? When you see this image, you will understand. It is the orbicularis oculi and the orbicularis oris. Orbicularis oculi and orbicularis oris muscles are the first one to get affected. Okay. After that, there's a peculiar involvement of muscles here. That's why you said, right? We have called it as fascio because the facial muscles, mainly orbicularis oculi and orbicularis oris, are affected. So that's why we use the term fascio. Next is the scapular region. Generally speaking, when we think of muscles, we think of muscles around the shoulder joint. But here, main muscle around the shoulder joint is deltoid, which is spared or not much affected. What gets affected here is the pectoral muscles and the scapular region muscles, right? What muscles we have? We have traps, right? The upper and lower trapezius, latissimus dorsi, rhomboids, and the subscapularis. So these scapular region muscles get affected. So what manifestations it will lead to when the scapular region muscles get affected? The scapular region muscle, right? It will lead to winging of scapula. So involvement of scapular region of muscles leads to winging of scapula. So these patients often present with, apart from initial evidence of facial weakness, they will present with winging of scapula. So whenever you see a patient, right, where he has some facial involvement and winging of scapula, first thing that should come to your mind is the facioscapulohumeral muscular dystrophy, right? Now, again, we understood why are we calling it as fascio and why are we calling it as scapulo. Why are we using the word humeral here? Because the biceps get involved. Deltoid relatively spared or gets involved quite late. Early deltoid is spared and the biceps get involved. Biceps get involved. Okay. And then in the lower limb, it is the tibialis anterior and the biceps femoris. These are the muscles which get involved in the lower limb. That is why when we broadly classified these disorders, I had called them as, what was the broad heading that we gave for this? Scapuloperoneal weakness, right? We had called it as scapuloperoneal weakness. Now, when you go through these images, you will understand what I'm talking about. What is the distribution of weakness, right? So in the first image, it's a patient with the facioscapulohumeral muscular dystrophy. Okay. And because of that, you can notice that there is some degree of facial weakness and some atrophic lesions. And you can clearly see when he was asked to protract, you can see that there is winging of scapula. Okay, that is usually the earliest manifestation. But as the time progresses, because deltoid gets spared, right, pectorals get involved, biceps get involved, forearm is spared, it leads to some examination findings which are usually asked as image based questions. And if you have a real patient, then these are kind of spotters in your bedside discussion. Okay. So first thing, you can see these two sets of images where this patient, this is a case of facioscapulohumeral dystrophy. You can see some bulges on the body, right? These bulges are because of certain pattern of muscle involvement. Okay. So what are the bulges you're seeing? One bulge you're seeing around the acromion process, right? Then you can see the bulge because of the trapezius, right? Then you can see a bulge of unaffected deltoid. This bulge of trapezius is because of what you call as dystrophy, right? Fibrofatty degeneration. Deltoid, which is not affected, right? Then subscapularis muscle giving rise to one more bulge. And then you can see a normal unaffected forearm also giving rise to one more bulge. This is not exactly how you can see the Popeye sign also, but this finding is what we call as, what do we call this finding as? This is called as polyhill sign. Polyhill sign, because on this patient you can see multiple hills, right? Multiple hills. So we call it as polyhill sign. Some of these hills are because of the dystrophy of the muscles. Some of these hills are not because of the dystrophy, but because of the normal unaffected muscles. Like the deltoid you see here is unaffected, giving rise to a sharp deltopectoral groove and one hill there. Okay. And as someone mentioned, you get one more sign. See, the lower limb predominant involvement is mainly the Duchenne and the Becker's muscular dystrophy. That is because the larger muscles get affected earlier than the smaller muscles. So when you talk about the shoulder girdle and the pelvic girdle and the arm and the leg muscles, obviously pelvic girdle and leg muscles are larger than the shoulder girdle or the arm muscles. So that is why in the Duchenne and Becker's, if muscle involvement happens, it is mostly lower limb first and then upper limb. In facioscapulohumeral, it is the face first, scapular region then, and then last is the lower limb, that is the peroneal region. Okay. Now, in this image, this is what is called as Popeye sign, and this is what I think is repeatedly appearing as image-based question in our exams. What is this? If you are familiar with the Popeye in the cartoons, right? You might notice that his biceps is smaller than his forearm, right? And the deltoids appear prominent. Deltoids appear prominent. Something similar you can see in patients with facioscapulohumeral dystrophy. So here you can see the traps which are dystrophic or much enlarged as if he is going to gym, right? Then you will notice that the deltoid has not lost the bulk, but humerus usually becomes atrophied, means the biceps becomes atrophied. So you have atrophic biceps and unaffected or spared deltoids. So this characteristically looks, and also unaffected forearm, right? You can notice unaffected or spared forearms. So this appearance is very similar to the anatomy of the Popeye. The deltoids not affected, biceps atrophied, and forearms not affected. So this sign, as Sayak Chakravarti has mentioned, is called as Popeye sign. So these are two important signs that you need to remember. These are repeatedly asked image-based question. Polyhill sign and Popeye sign. Both of them are seen in which type of muscular dystrophy? It is the facioscapulohumeral muscular dystrophy. Clear? So we have learned about two inherited dystrophies today. The first one was Duchenne muscular dystrophy and the second one was facioscapulohumeral muscular dystrophy. There are two more that we will discuss in the next session. The limb girdle muscular dystrophy and Emery-Dreifuss dystrophy, and then after that we will start with the neuromuscular junction disorders. There are also another set of disorders that is pending for our discussion, that is inflammatory myopathies, that we will better understand when we talk about the rheumatological disorders. Like along with our discussion of rheumatoid arthritis and SLE, we will be able to understand that better. So for today, that's it, guys. I will see you day after tomorrow. We will be talking about Emery-Dreifuss muscular dystrophy and limb girdle muscular dystrophy. The reason I'm splitting it into two is it also helps us to have a comparative idea. So if you revise what we have done today, then you can compare what we will be studying in the next session with the information that you have from the previous session, and then we will take it up from there to the neuromuscular junction disorders. Okay. So I'll see you in the next session. Till then, have a good day.